हेलो एवरीवन, गुड मॉर्निंग। मैं डॉक्टर सुनीता फिर से मैं आपको नया कुछ बताने के लिए आई हूँ। आप मेरे चैनल को लाइक, सब्सक्राइब और कमेंट ज़रूर कीजिए, जिससे मैं आपको और नए नए वीडियो बना के भेजती रहूँ, जिससे हमारा भी मोटिवेशनल बढ़ता रहता है और आपको भी जानकारी मिलती रहती है। और कुछ ऐसे टॉपिक्स हैं जो जिसके लिए आपको कुछ नॉलेज चाहिए या कुछ आपको पढ़ना है या कुछ वो टॉपिक के बारे में आप जानना चाहते हैं, तो मेरे उस पर कमेंट्स कर दीजिए या मुझे पर्सनल फ़ोन कर दीजिए, तो मैं उस टॉपिक पर भी आपको वीडियो बना के भेज दूँगी। तो आज मैं बनाने वाली हूँ क्रॉनिक किडनी डिसीज़ एनीमिया पर, जो बहुत ही ज़रूरी है। क्रॉनिक किडनी डिसीज़ मतलब anemia of CKD is defined as a hemoglobin less than 12 gram per deciliter in female or less than 13.5 gram per deciliter in male, with adequate iron availability by the parameters. The transferrin saturation is more than 20% and the ferritin is more than 100 nanogram per milliliter. In CKD stage 5, the ferritin target is more than 200 Ng per ml, and anemia of CKD usually begin during the CKD stage 3, that is the GFR is less than 60 ml per minute per 1.73 m2. Anemia occur in 42% and 54% and 76% of CKD stage 3, 4 and 5 patient respectively, and is more severe in diabetic patient. That is more prone, that diabetic patient is more prone for CKD and more prone for this anemia. So we care about who have in our family डायबिटीज़ और सीकेडी, तो अभी से अपन को उनकी केयर करनी होगी। तो आप तैयार रहिए, अपनी खुद की भी हेल्प करने के लिए आप तैयार रहिए और अपने जो नियर एंड डियर हैं उनकी भी हेल्प करने के लिए आप तैयार रहिए। मेरा ये टॉपिक है, इस पर मैंने अभी इतना सिर्फ इंट्रोडक्शन बताया, बाकी मैं पूरा ये टॉपिक आपको बताने वाली हूँ, तो आप सुनते रहिए बिल्कुल मेरे साथ। Etiology of CKD disease in anemia. The anemia of chronic illness traditionally encompassed an inflammatory, infectious or malignant disease for a long-standing nature. The modern definition include rheumatoid arthritis, severe trauma, heart disease, and the diabetes mellitus. In these conditions, there is a primarily a decreased availability of iron, relatively decreased level of erythropoietin, and a mild decrease in the lifespan of RVC, that is 70 to 80, normally that is the 120 days. Relatively recently, the hepcidin and endogenous antimicrobial peptide secreted by the liver has been identified as a controlling the level of plasma iron by regulating the intestinal absorption of dietary iron as well as the release of iron from the macrophages and the transfer of iron stored in the hepatocytes. Increase in hepcidin level in the course of inflammatory disease may be a significant mediator of the accompanying anemia. Another proposed mechanism for anemia of chronic illness deals the cytokines and such as interleukin 1 and interleukin 6, and the tumor necrosis factor alpha, which is believed to cause a destruction of RBC precursors and decrease the number of erythropoietin receptor on the progenitor cell. Whereas the hypoxia in the individual with normal and functioning kidney leads to erythropoietin gene transcription and hence increased RBC production. In those with the anemia of chronic kidney disease, there is a primary deficiency of the erythropoietin production by the interstitial fibroblast and also known as the type 1 interstitial cell, thereby leading to anemia. The anemia that develops is directly related to the amount of residual renal function. The kidney are responsible for approximately 90% of erythropoietin production in an individual. The pathophysiology primary reason for anemia is CKD. In CKD is an absolute or relative deficiency of renal erythropoietin synthesis. Individual sensitivity and responsiveness to an ESA is highly variable and dosing requirements are heterogeneous. Occult causes of blood loss and iron deficiency must be ruled out in all patients as a cause of responsiveness to ESA treatment. Less commonly, vitamin deficiency, that is B12 and folate, and inflammatory causes of ESA resistance should be ruled out secondarily. Inflammation upregulates hepcidin and liver synthesized protein that reduce gut iron absorption and impede iron release from the reticuloendothelial system to the developing erythroid. Finally, effective iron delivery is required to optimal ESA stimulated production of fully hemoglobinized red blood cells. Chronic presentation. Chronic presentation, chronic kidney disease anemia is often diagnosed by routine review blood test. Renal anemia may lead to the onset or aggravation of the lethargy, cold intolerance and loss of stamina. Anemia increase cardiac output, therefore the contributing to the development of left ventricular hypertrophy and dilatation. The evaluation investigating the patient with CKD, if their hemoglobin falls level 11 gram per deciliter or less, they get symptom due to anemia such as tiredness or breathlessness. This will involve ruling out other causes of anemia, assessment of kidney function, assessment of any cardiovascular and other complication of anemia or CKD. Kidney function, GFR and electrolytes, FVC, blood film, iron studies and B12 folate where ferritin and 11 less than 100 microgram per liter. There is an iron deficiency anemia. If the ferritin is above this level, a functional iron deficiency is defined by the percentage of hypochromic red cells more than 6% or otherwise transferritin saturation is less than 20%. Other investigation will be determined by the likely alternative diagnosis and cardiovascular effect of anemia. Example TFTS, renal ultrasound, echocardiography, investigation for the gastrointestinal bleeding, management. The treatment of erythropoiesis stimulating agents should be offered to patients with anemia of CKD who are likely to benefit in terms of quality of life and physical function. There are few studies comparing the efficacy of various agents. One study reported that darbepoetin alpha weekly or every 2 weeks was more efficient in the achieving the target hemoglobin than those on weekly epoetin alpha. With fewer dose changes, the minor vascular access complication, the time taken for erythropoietin treatment to be effective will be depend on individual patient factors such as degree of anemia, degree of kidney disease and the presence of other adverse effects. factors. Example, iron deficiency. Contraindication for erythropoietin treatment include uncontrolled hypertension. Potential side effect of erythropoietin include increase in blood pressure or aggravation of hypertension, headache, increase in platelet count, influenza-like symptom may be reduced if intravenous injection is given over the 5-minute thromboembolic event. Pure red cells aplasia, hyperkalemia, and skin reaction increase concern over the risk of cardiovascular event have led to the reduction in the use of erythropoietin as a group in the recent years. There have been very rare reports of the pure red cell aplasia in the patient treated with the erythropoietin alpha. The Commission on the Human Medicine has advised that the patient developing erythropoietin alpha failure and a diagnosis of pure red aplasia, treatment with erythropoietin alpha must be discontinued and testing for the erythropoietin antibodies considered. A patient who develop pure red aplasia should not be switched to another erythropoietin. In people with anemia of CKD, hemoglobin should be monitored every 2 to 4 weeks in the induction phase of erythropoietin stimulating agent therapy, every 1 to 3 months in the maintenance phase of erythropoiesis stimulating agent therapy, more actively after dose adjustment of the erythropoiesis stimulating agent erythropoietin alpha. Erythropoietin recombinant human erythropoietin is used for anemia associated with erythropoietin deficiency in CKD. The clinical efficacy of erythropoietin alpha and erythropoietin beta is similar. It is also used to increase the yield of autologous blood in normal individual and to shorten the period of anemia in patients with receiving cytotoxic chemotherapy. Erythropoietin beta is also used for the prevention of anemia in preterm neonates of low birth weight. Methoxy polyethylene glycol erythropoietin beta is a continuous erythropoietin receptor activator. It is licensed for the treatment of anemia associated with CKD in patients who are symptomatic. It has longer duration of action than erythropoietin. Other factors which contribute to anemia of CKD, that is example iron folate deficiency, should be corrected before treatment and monitored during therapy. Aluminum toxicity, concurrent infection or the other inflammatory disease may impair the response of erythropoietin. Thank you. So nice of you to listening this topic, and this I hope this topic is very useful for you in CKD, who have CKD, who have diabetic. Okay, good day. Thank you. So nice of you. Like and comments and subscribe my channel. Thank you.